everybody is about to go down. So ladies and gentlemen, here are your early stage finalists. Elias Biosciences. IntelliDiage. Minerva. Micro Innovate Hub. One Click Med. Savvy General Trading PLC. Seizure Guard. Snoocode Red Limited. Staying Smart. Rise Beyond Organization. And then the last venture, Karanj. Thank you very much. Before we begin, I would like to introduce our judges. So judges, when I introduce you, please make your way to the panel, the table right there. First off, we have Osaretin Obano from the University of Toronto and the Africa Impact Initiative. Round of applause for him, ladies and gentlemen. We have Diane Uyoga from Moi University. We have Dr. Fafa Adobuate, Innovators Global Health and in Sub-Saharan Africa. Jessica Boyfield from Ashesi University. And Dr. Yao Bediakon, Ashesi University and Yamachi Biotech. Thank you very much. A few rules for this round. We have 5 minutes to pitch, and 5 minutes of feedback from the judges. So 10 minutes for each venture in all. 5 minutes to pitch, 5 minutes for feedback. Ladies and gentlemen, let's get right into it. I would like to introduce the first. Oh, 2 minutes. Okay. 2 minutes. Is everybody excited for dinner later tonight? Are you? All right, now you are too tense to be excited. Please relax, okay? So dinner is happening later today at 6:30 p.m. Dress code is anything, but with a touch of African in there. So we are looking forward. It's going to happen right here in the Cedar Hall. We are looking forward to have a great time after this wonderful 3-day conference. Festival, not conference. All right. And ventures, please be reminded, finalists, please be reminded that on this podium, we have a microphone here and we have a clicker. So when you come, you can make use of that during your presentation. All right. Ladies and gentlemen, we are all set to go. So please help me welcome the first early stage finalist, Elias Biosciences. Round of applause for them.
Hello. Hi, everyone. Good afternoon. My name is Michael Dakuwa-Usu. I am a medical laboratory scientist. I want you to remember a time where you got your medical treatment delayed because your medical diagnostics got delayed. Remember the frustration you went through waiting 2-3 hours for a test, not knowing what to do, just waiting on the doctor who is also waiting on the lab. Remember the frustration. Now I want you to imagine traveling 3 hours from your district to a completely different district just to access a test as simple as a complete blood count. A journey which means your report is going to take more than 24 hours for a simple FBC that takes just 10 minutes. This is the reality of 145,000 people living in the Bekwai municipality in the Ashanti region of Ghana. There are 166 communities sharing only 25 health facilities. And the sad thing is, most of these health facilities lack basic laboratory testing capacity. There are no MRI or CT in the region. Elias Biosciences has a physical infrastructure where we have 3 out of 6 of our principal testing machines, which means we cover 40% of basic laboratory routine diagnostics there. Our model is simple. Clinicians from all 25 facilities request their labs to us. We process the sample. Those who cannot come to us, we have a dedicated courier service the flyers are sharing around, and we go to the communities and pick the sample up to the lab. After processing, we send a report via WhatsApp to all the clinicians and the clients who used our service. The people trust us because we are part of them. I am from there myself. We have frictionless access, and we have the National Health Insurance Scheme, which means vulnerable people and the poor can access us without the fuss of stressing about the financials of healthcare. We've been operating for 30 months, and we've generated $17,000 in revenue since April 2025. Last year, we conducted 1,228 tests across 49 distinct tests. These are tests that would have gone outside Bekwai if we weren't around. We have multiple income generation streams, which helped us get the 17,000. We raised an initial $32,500 in seed funding and acquired a grant of 1,600 from LENFI. Our annualized run rate is 16,200, and our average monthly expenditure is 1,600. We are close to breaking even. That is why we are asking for 45,000 to get the remaining 3 machines that we need to cover 80% of basic laboratory routine diagnostics and more. This investment will mean 10% of equity shares, and we are going to make profit when we get this money. In 4 years' time, with our 15% growth imagination, we want to be able to get X-ray and a microbiology setup, which will see us getting 100% of basic laboratory testing, basic laboratory routine testing capacity in Bekwai. Bekwai is not only our focus. There are about 199 other districts in Ghana who share similar realities. And we've built relationship with 3 of these districts where we have champions and relationship with the community leads. When we are ready to go there, the market will be ready for us. This is our lean team of 4 graduates who have distinct experiences complementing each other. We have the partnership. We have the community network. Our ask here is for you to help us bridge the diagnostic gap in rural Ghana. Thank you very much.
Thank you very much. All right. Judges?
Thank you so much for the presentation. Very well done. My first question is more around data. So when you get the results, you send it back to the clinicians via WhatsApp. So effectively, you do not control that line of communication. So people's lab results are sitting on physicians' WhatsApp chat messages, basically. how are you safeguarding client data or patient data that way? Since you don't own that, might it not be a better approach to figure out how you can control the messaging of the results back to the clinicians?
Okay, thank you very much. The thing with data safety is every result that we send comes with a password. We save it in PDF, and we put a password to it. And we make sure we send it directly to the clinician and the client's WhatsApp. And we share the password with them. Going forward in future, I want to announce this, though I didn't talk about it. We have created our own laboratory management system called Labora 360. It's online. Anybody can just search it. We did it with Love Designs, and it's still under testing. And we want to use that to manage our laboratory information data going forward, so we won't have any more WhatsApp, and the data security will be solid. Thank you.
Thank you very much. The other question I have you is more around your valuation. You put on the screen that you're asking for $45,000 for a 10% equity share, meaning that you're valuing your business at around 450,000 USD. Is there like some logic behind that math you did, or is it just something just trying to get an understanding of your?
Yes, the evaluation was done based on the current interest rate at the Treasury bill, which is the safest investment anybody can make in Ghana. So with our assets that we currently hold and the expertise that we have, we've valued ourselves around 450,000. It may seem small, but we can go higher. But yes, for where we are now, I feel that the 45,000 will do more good for us and catapulting us to the next stage where we can scale into other districts.
Okay, I just have a couple of questions about your lab. So what certifications does your lab have? Are you HEFRA approved, Ghana FDA? And then in terms of data, like you were asked, are you registered with the Ghana Data Protection Act? So those three.
Yeah, we have the HEFRA certification. We do not work directly with FDA, so we don't have FDA. It's not a requirement for us. Maybe going forward, if we try to do some food testing, we have to go to them. And with the data protection with Ghana Data Security, we are not yet there because we are still testing we just launched it last week, so we want to see if it works first, and we can use it for ourselves before we can even sell it to other and also use that as a revenue generating stream for ourselves. Yeah.
Okay, I think you might want to double check because typically labs in Ghana are typically certified by FDA as well. So, no, I have a diagnostic lab. I know what I'm talking about.
Wow,
yeah.
I didn't know
that. So, HEFRA does that, but Ghana FDA also can do spot checks. So it's a good idea to explore that.
Yeah, I have the FDA number. I can call them. Thank you.
Okay. And then the other thing I wanted to ask is, generally, in terms of your projections, what happens when the Ghana government builds a public lab in Bekwai that has all this capacity, which is what it should be, right? You are currently doing something that should be taken up by the public sector. What happens when tomorrow President Mahama announces we are going to build a $200,000 lab in Bekwai? What happens to your business?
Yes. Actually, the Ghana Medical Association has actually launched that. They want to build a lab in every region, which is the 16 regions. We are not threatened. We feel that the people identify with us. They trust us because we are part of them. And the service that we provide, especially with the LIS delivery system, we go to the people where there are bad roads, they are isolated communities. We go directly to them and pick their sample and bring it to us. So they feel more appreciated because we are taking the lab to them, not them coming to us. And most of these people are farmers and they cannot really afford to travel around like that. So we are not threatened. We rather welcome it because we can partner with them and outsource some of their labs whenever there's a equipment breakdown. And we all know the turnaround time for equipment management when it breaks down in the district government infrastructures. We all know.
Thank you very much. Thank you very much. Ladies and gentlemen, shall we give him a round of applause?
Yeah.
I want to make a comment. The 40% coverage It's actually 80% of the labs listed here. So we are small, but we do a lot.
Thank you. Up next, we have IntelliDiag. IntelliDiag, if they are here. Am I mentioning the name right? IntelliDiag. Diag. Oh, okay. IntelliDiag. Okay. Sorry for left. All right.
Hello, everyone. My name is Kwame and I'm the CEO for IntelliDiag. Now, I want us to follow this story clearly. So let's talk about Kofi. Kofi is a 42-year-old teacher in Kumasi. He's been working. We know the work is tiring, but at a point, he starts to feel dizzy. He's been getting persistent blurry vision and severe headaches, sharp ones. So he decides to go to the hospital. And then his doctor requests for an MRI scan. He takes the scan, but he's promised a day before analysis. A day turns to 3 days, then 11 days, then weeks, months, and he's still sitting in a folder. And this is not just about Kofi. This is about the 1.4 billion Africans who have limited access to radiologists and specialists for medical imaging diagnostics. We say that in a million people in Africa, there's just one specialist to serve them. And this is causing a delay in diagnostic and interpretation of images, causing about 70% errors in diagnostics and late disease detection. Ideally, we'd want that after Kofi took his medical image, it would have been analyzed, interpreted, and later we could go on with his disease treatment. But this didn't happen. Research shows that there's 60% turnaround decrease when it comes to AI in healthcare assisting us in delivering services. And this increases survival rate by 50%. And that is where IntelliDiag comes in. IntelliDiag is a web-based platform that leverages AI and artificial intelligence to help with disease diagnostics, with interpretation of medical images, giving confidence scores. IntelliDiag is not here to replace our radiologists and our specialists. IntelliDiag is here to help them make more accurate and fast and informed decisions to help us with interpretation of data, medical images, medical scans, MRI, CT, or any other scan to help us with early disease detection. Also, IntelliDiag is accessible, easily accessible. It's a software as a service. All you need is a laptop and your data, and then you can make interpretation with confidence score, informing you of what kind of disease or cancer or any at all that it could be. We are not in the market alone. We have key players in the market doing things similar to what IntelliDiag is doing. But what makes IntelliDiag different, what makes IntelliDiag outstanding, is these things I've listed there. We are looking at AfyaFest. Because we understand internet connectivity problems in Africa, we are working on ways to give low bandwidth. And we are looking at operations in West Africa especially. There's the market opportunity. There is an expected growth by 2030 of $450 million in healthcare AI in Africa, narrowing down to a serviceable obtainable market of $6 million. Yes, this is the team. So the team is a multidisciplinary team. We have a researcher, a radiologist. We have lecturers and researchers helping the team, computer engineers and biomedical engineers. We've had a demo on, with a patient in Nkrumah Teaching Hospital. We have an informed product roadmap, practicing with a radiologist, and we have 4+ AI models deployed. Help us reach every Kofi. Help us reach every African who is having a problem with getting his or her disease diagnosed. Let's solve the problem of disease diagnostics. We are asking for 100,000. Thank you.
Judges?
Should I go? Thank you. Okay. Thank you. Thank you for the presentation. It was clear and concise, and I like the way you started with a sort of real-life person and walking through that journey. What I'm missing is, I'm not sure I understand what the pitch is. Is it a software, or is this a laboratory or a diagnostic facility? I'm not sure I got that quite clearly. And also, can you tell me what your background is? What's your background? And why IntelliDiag, right? Okay.
IntelliDiag is a software. Yes, please. I'm a computer engineering student in KUST. I've been doing robotics and AI stuff for some time, but the team has a radiologist on board, and we have other people from biomedical engineering as well.
Okay, thank you so much, Coffee team. My question is around competitiveness. I noticed that your product does not operate where there is no internet coverage. And you're going to have your product in the African countries where there is minimal network coverage. How do you propose to work around that?
Currently, we are looking at ways to work around that, not just have a web app, but a mobile app, one that's accessible offline. Yes, please.
I have a question about your model. So how many patients have you trained it on? What data was the model trained on? Yeah, so how many patients, and where were those patients from?
Okay, so we have, for data source, we have been using BRATS and Unidata. There are open source medical imaging data sets that we've been making use of, some from Cargill. But since we are looking more at Africa, we are looking at Africa. We've been using BRATS and this open source breast cancer imaging data set. Yes, please.
But how many? You should know how many images have been fed into your model. So those are the sources, but how many images did you use to build your model? And have you benchmarked your model against existing radiology AI models elsewhere?
So I'll answer the last question first. We've tested the model on just one patient from Nkrumah Teaching Hospital with the help of the radiologist on the team. I mean, it's something health related, so we have to seek consent from the patient since we are now working on licensing, but we've worked with one patient yet tested. And how many data we fed into the model?
Yeah, but I mean, like with models, you know, like you can calculate the accuracy, right?
Yes, please.
So your false discovery rate, your false positive, false negative. So what are those metrics for the model?
So with model analysis, we started clocking like 94% accuracy rate with disease detection, like particularly with brain tumor analysis and mammograms for breast cancer analysis. And then we moved on to lung cancer. We were looking at some MRIs and CT scans from lung cancer, and we were going higher, sometimes 93, 96, 94%. Yes, please.
Thank you so much. Great work. My question is really just around your business model, pricing, etc. Could you walk us through how much this will cost the average clinic to take advantage of, and yeah.
So with our business model plan, we're looking at working with first B2B and then B2G. So we're partnering with the Ministry of Health and the government, and with the B2B model, we're looking at various hospitals. So since it's a software, we're looking at subscriptions. So pay by subscriptions, and we're looking at 3 different plans: the basic, the pro, and the enterprise. Where the basic, we are looking at $10 per month per 10 users for a hospital, and if you are going for pro, then we are looking at $30 per month per 10 users, and enterprise $90 per month per 10 users. And all these plans come with different things. We're going to give you upgraded models and all that. Yes, please.
Okay, we have 30 seconds left. So you've only tested it on one patient, but when do you expect to start paying for this model? You just listed but who is going to pay for a license for a software that's only been tested on one patient?
Currently, we are working on piloting with Nkrumah Teaching Hospital and KUST Hospital.
Thank you.
Thank you, too.
Thank you, IntelliDiag. Up next, we have Minerva. Minerva. Round of applause for Minerva.
Good afternoon. My name is Yvonne Kaveta, and I'm the founder of Minerva Health. In 2023, my sister severely bled out after giving birth to twin girls, and by the time doctors noticed, it was already too late to intervene. According to the World Health Organization, approximately 6,000 women in Kenya die every year from pregnancy-related complications, with the leading cause being excessive bleeding. And this is because currently there is no system in place to detect the risk of severe bleeding after a woman gives birth. And in the event that bleeding is noticed, sometimes help often comes too late, and this results to untimely death. To solve this problem, we have designed an early warning system that can help frontline healthcare workers to be able to detect the risk of bleeding out after a woman gives birth during the first 24 hours after delivering. And how does our solution work? We have designed a wearable belt that consists of biosensors that will be able to track the vitals of a woman. The biosensors will measure the amount of blood lost, the changes in temperature, and the uterine tone, which is the firmness of the muscles around the abdomen. Why is our solution better? For the first time ever, frontline healthcare workers will be able to be equipped with a solution that helps them to act faster, accurately, and more reliable to make sure that no woman dies after giving birth just because bleeding signs were noticed late. This is not a new problem. There are many people who are working towards making sure that women do not die from excessive bleeding. There is Jacaranda that provides healthcare information to women so that they can be able to understand the danger signs that come with pregnancy. And we also have the PPH drip, which is a calibrated plastic bag that a woman that the frontline healthcare workers use to collect and measure the amount of blood lost. However, these solutions are reactive. We offer a proactive solution, and through our system, healthcare front workers will be able to proactively monitor the signs of the woman, and through our predictive AI dashboard, the vitals will be able to be analyzed, and in the event of a high risk or low risk postpartum hemorrhage, the frontline healthcare worker will be able to be alerted and provide intervention on how they can act faster. We also have an added advantage of offline access, which means that if there is no electricity or there is no internet, our solution will be able to run, and also an added advantage of using Kiswahili, which is the most spoken language in Kenya. To make sure that we understand the needs of the people we are targeting, we conducted over 30 interviews with doctors, midwives, and mothers, and they confirmed a strong need for a solution. We also reached out to hospitals, and 5 of them are currently on our waitlist and are committed to partnering with us to do clinical trials in the events that we roll out into the market. We have also established a network of 18 community healthcare workers who are committed to go through our training so they can be able to use our solution. And so far, we have managed to raise $3,000 from incubator programs that we've been able to use to train our AI dashboard and do research and development on our prototype. When I designed this solution, I had my sister in mind. But when we started doing the research, we noticed that this is a problem that a lot of families face. Mothers are lost, loved ones are lost, and children lose their mothers and become orphans throughout the way. So we have a total addressable market in the sub-Saharan Africa where maternal deaths are the leading health crisis in the health space. And in Kenya, we cover $8.75 million in targeted healthcare solutions. We aim to sell our product to hospitals and medical schools so that they can use it to train their frontline healthcare workers. And we are looking to sell this at $150 after developing with less than 50 locally sourced materials from Kenya, given the dramatically low cost of biosensors currently. So far, we are waiting for the approval from the Ministry of Health, and are in partnership with the Dutch government under her sconing that is going to help us do clinical trials and ethics clearance, as well as test our solution. Our team consists of medical doctors, product design lead who is based in Canada, and Audrey Ashlin, who is my co-founder and the chief technical officer, and we are backed by Doctors Without Borders. Today, we are seeking $5,000 to be able to work on our wearable belt and make sure that we integrate the solution together with our dashboard and make sure that no mother dies while giving birth just because the warning signs were acted upon late or not detected earlier. Thank you.
Judges?
Yeah, thank you for that presentation. And I want to find out more. Where does the data go to? As in the information is conveyed, and who acts upon it? Is it the person who is wearing, or how does it go about? Because it didn't come out so clearly.
Yeah. So the data goes to the dashboard that the healthcare frontline workers will be using. So that is the midwives or the nurses that are in rotations. So it's not the woman who has access to their data. However, we work on consensual terms with the woman. If the woman agrees to have their vitals monitored, then they'll be able to use our solution.
So I'd like to understand how it works. So what is the engineering behind the design? What are you measuring?
Yeah, can I show you my live demo, please?
Sure. Well, we don't have a lot of time. Just explain to me, not so much how I would use it. I want to understand the science behind it. What are you measuring from your wearable?
Yeah. We're measuring the changes in temperature around the abdomen using a thermostat, and we're also using EMGs and ECGs to measure the changes in blood pressure and the uterine tone, which is the firmness of the uterus and muscle tightness.
Okay, and then your AI is going to integrate that.
Yeah, so the biosensors feed into our AI that is able to analyze these vitals, and how we've trained them is to make sure that from this matrix, is this woman at a risk of bleeding out or not? If the risk is high, then the rotating birth attendant gets alerted and they can be able to intervene in time.
Okay, so how validated, how far along? Do you have a prototype? Have you tested it in pregnant women? What is the success rate? Do you have any of that data?
So far, we have worked on programming our AI dashboard, and we are currently doing the prototype for our belt. And that is why we are partnering with doctors so that we can be doctors and hospitals, so that you can be able to do clinical trials in the event of approval by the Ministry of Health.
Sorry, I'm confused. How do you program your AI?
AI that can basically, from vitals, predict whether someone is at risk of bleeding out, correct?
Yes.
Have you thought about, while you develop something physical to fit into that, have you thought about starting with that as an actual solution? Is that like a thing? I don't know if it's viable, but just sort of encouraging you to think about what you already have and what value you can get from that while you're still building the hardware, which might take a bit of time.
Yeah, thank you for that.
I'm still, thank you for the pitch. I'm a medical doctor, so I'm still trying to understand the solution.
Yeah.
Although this is a very impressive presentation, I'm just thinking about how this works in practice with the nurses and the patient.
Yeah.
You know, because there are already existing solutions for managing PPH.
Yeah.
So obviously you're working with doctors, so you've probably thought holistically about it. Where does the patient come in? Where do the nurses come in?
Yeah.
I mean, we know that our facilities, especially the public sector, can be quite congested.
Yeah.
So what is the reaction time? I'm just still thinking of, it sounds like a great innovation if you can combine it with existing solutions
yes.
that are proven to work.
Mm-hmm.
So yeah, I'm still thinking. So how does that work, like all together? Like a patient comes in and then what? I know I'll ask that question, but it's still not totally clear to me.
So, as I had mentioned, we have the wearable, which consists of the belt. So the belt is a smart belt that has biosensors. It is able to connect to the dashboard using Bluetooth. It can be monitored from anywhere. So what we provide the frontline healthcare worker with is the dashboard. However, it's not technical for them to understand. What they receive is an early warning system after the biosensor feeds to the dashboard. So they can be able to intervene in time, because also in as much as the dashboard is analyzing and providing the early warning system, it is also providing recommendations on how they can go about it. If it's to provide abdominal massages to make sure that the uterus contracts, then they can be told to do that by the AI, but also in the event that maybe there is low oxytocin, which can be measured by our biosensors, they'll be able to know that this patient needs to be administered oxytocin.
Thank you very much. Round of applause for Menava. Thank you very much. Up next, we have Metagrade. Metagrade. Round of applause for Metagrade. Do we have a rep from Metagrade here? All right, moving on. Up next, we have Micro Innovate Hub. One Click Med. One Click Med. Let's welcome them. One Click Med.
Okay, starting now. There are things you hear about and think, that would never be me. And that was me 3 years ago when I watched my mother lying helpless in the hospital. She was going into surgery. It was a corrective arm surgery, so because it's a common surgery, I told myself she'll be fine. But her surgery didn't happen that day because her records couldn't be found, so they asked her to wait. And she waited through the afternoon, through the evening, through the night, in severe pains. And it was suffering for her, measured in minutes. I paid twice, I stressed twice, but she hurt twice. The hardest part was sitting next to her, not being able to fix it. And as a pharmacist, I know that there's a record there in that hospital that would end her pain, but no one could find it. She went into surgery the next day, and standing in that hospital corridor, I asked myself just one question. How many people are going through this right now? Not because doctors failed them, but because a file had gone missing. And here's the problem. 80% of hospitals still rely on manual records in Nigeria, with patient medical histories scattered across multiple facilities and zero data transfer between these hospitals. And here's what we built: an end-to-end digital health ecosystem, an EHR system built on FHIR standards to ensure compatibility across health networks, with flexible architecture connecting labs, pharmacies, and insurance providers, allowing for secure flow of patient information between different healthcare facilities instantly, empowering patients with real-time access to their medical history, labs, and appointments. And here's how it works. A patient visits the facility, reception creates profile and enter vitals into an EHR. Encrypted medical data syncs instantly to a secure cloud via an API. Patients can view their records, labs, and link hospitals in real time on the patient app. Data is available instantly at the next facility, preventing gaps. And this is what the EHR looks like: digitized paper record, automated billing, inventory and staff management. And for the patient, you have real-time record access. There's an offline functionality. And for the premium, you have emergency response services, direct lab result access, and telemetry consultations. For the business model, our B2B SaaS model costs $80 per license per year. And our B2C for the patient is 15 to 30%, gotten from emergency response services, telemedicine, and lab access. Our unit economics, our customer acquisition cost is $150 per hospital user. Our LTV to CAC ratio is 16:1, and our payback period is 7.5 months. And then our market opportunity, the total addressable market is Africa's $5.58 billion digital health market, out of which we extracted our serviceable addressable market, which is Nigeria. Our serviceable obtainable market is Lagos and Abuja, and we want to obtain 10% of that in the next 5 years. And in our unique value proposition, first, unlike siloed systems, we offer a complete platform combining hospital EHR and patient hubs. And then we are integrate seamlessly with existing hospital infrastructure rather than forcing an expensive replacement. So we integrate with whatever infrastructure a hospital already has rather than forcing an expensive replacement. And we are engineered specifically with offline first capabilities for low bandwidth. And in our competitive landscape, we have other players in the field, but OneClickMed currently offers an end-to-end ecosystem, a system integration with patient hub, data security and privacy, cost effectiveness for mid-low level hospitals, and then we are bridging the gap between affordability and high-tech integration. And attraction, since launch, we've made some progress. We've been able to pilot with 3 hospitals plus a secured partnership with a health partner, giving us access to 30 more hospitals. We've digitized over 3,200 records, have over 650 patients record their health, assess their health via the Better Health app. We've gotten 85% satisfaction rate from our customers, and then we've secured strategic partnership as well. Our team has a combined experience of over 50 years. I am a pharmacist with over 5 years of experience in patient care innovation, product management, and digital health. And our founder is an ICT consultant with a decade experience. Okay, our hack is $10,000 USD to expand from 3 hospitals to 15 hospitals and get more of our users from over 650 to 5,000. My mother waited 24 hours in pain because just a file couldn't be found. I believe somewhere in Africa right now, someone's mother is waiting too. The difference between our story and my mother's story is how far we scale what we've built. So help us scale it. Thank you.
Thank you very much, judges.
Thank you very much. Can you tell me a little bit about the 3, you said you piloted in 3 hospitals. Can you walk us through one of them and what the outcome is so far?
Okay, so the hospital we piloted in was a government hospital in east of Nigeria, but in Enugu State. So we told them they have a doctor, and then it's like a mid-sized government hospital. So they have a doctor, they have several nurses, and then they have a lab scientist, they have a nurse, they have a doctor, they have a front desk. So the system is built in such a way that it is interoperable. You have a doctor on the platform, you have a nurse, you have a lab scientist. So we went there for the onboarding. We had a session with them, demoed them, and then we also created a profile for each of them, and then the system is a role-based access control, so you only have access to the information and the data that you have. And then after we did that for them, we were also able to walk them through the process of digitizing their patient records, and then they got about over 1,000 of their records digitized on the platform, and they're constantly using the platform daily. And then we provided a support for them, a 3-month post support in case they had any issue. We tell them to reach out to us and we put them through. And so far, the only issue they've had is when they have a new hire, they have to just go through it and then to know how the system really works, how hand in hand. So, okay.
Thank you. So what are they using? I'm trying to understand.
Okay.
You spoke about, interconnectivity between systems in a facility. Like, what are they actually doing with this tool that you have implemented in that facility, and what is the outcome now? What are the benefits or the impacts of the solution that you?
Okay, thank you for that question. So I mentioned the fact that it's an interoperable system. So there's a EHR for the patient, for the hospital, and also the patient hub for the clinic. So what we've gotten so far is the fact that because now they have patients that also, they tell them to download the patient hub. So now they have their access. They have access to their records. And not all their records, of course, their allergies and the likes, because it's a case where it's very close to the places where patient travels a lot. And then when they travel, they still have access to their records because it's interconnected. So the feedback we've gotten so far is that they've had patients download the patient app and also have access to their records, which they also have in the hospital. So if they travel to another state or go elsewhere, they still have their access. They don't have to start another test again. They don't have to do any other thing again. They still have access to their records the way they also have access to their record at home. And when they come back, their record is still secure. And data is encrypted, so their safety is assured.
All right. Okay, I'm only going to ask one of my questions because there's not that much time. You're playing in the EHR space that's very convoluted. There are a lot of players there, specifically in Nigeria. Helium Health probably owns most of the market.
Yes.
You went through that slide pretty quickly, but I want to understand how exactly you're planning to uproot Helium Health from majority of the market.
Okay, so we are not planning to uproot Helium Health, but how we stand out. Okay, so I'm just going to go back. Okay, so how we stand out is that a comprehensive EMR system is just one of the things we do. They also offer an end-to-end ecosystem, system integration with patient hub, which Helium Health currently does not have. Then we have a cost effectiveness for mid-low level hospitals. Helium Health plays in the big field, but we made our cost so cost effective that a private clinic that has just one doctor that just founded it can afford it. So that is where we play out. So where we really stand out is the fact that we are bridging the gap between their affordability and high-tech integration. Another thing we have is we have seamless integration. So if you get to your hospital and you have like a database you store your patient data in, we don't tell you to replace it. We can integrate seamlessly with whatever you have without asking you to play out to maybe remove whatever you're using. So that's how we stand out.
Maybe in line with that, so for the hospitals that you work in, what % of the patient records are on your system? That's my first question. My second question is, where is that data being stored? Is it on premises or is it in the cloud?
It's in the cloud.
Okay, if it's in the cloud, then what happens if you go out of business? What happens to that data? I'm asking because doctors in Ghana know what that feels like right now.
Okay.
So how secure is the hospital's data if one-click med is not there tomorrow?
Okay, so first I'm going to answer the second question. And then I want to say that although it is not evitable, but we are not planning to just leave our patient hanging, although that is not evitable. But yes, our sister was said that it is HIPAA compliant, right? And then when I was thinking about how it works, I said that the system syncs instantly into a secure cloud via an API. So we store it in such a way that wherever it is, your system, your profile is, and it's HIPAA compliant. So it's secured. You have it in one place in the cloud, and it is very secured. So even though, what's it called? One-click does not exist tomorrow and we are out of business, they still have access to their records, and then we have a consent form where we get them on board to be able to have all these records in one place.
What are your cloud costs on a monthly basis for your 3 hospitals?
Okay, so recently we just changed our architecture into AWS because it is more efficient. But currently we have, I think we got a free, I really don't remember, but I think we got a free credit for some time to be able to use it before paying for the AWS cloud architecture.
Yeah, so I think you need to think about that because if you go out of business, AWS will not release the data.
Oh, yes.
So that's something your hospitals are going to be very concerned about if they do their homework. So it's something to really keep in mind.
Thank you.
Thank you.
Thank you.
Okay.
Thank you very much, One Click Med. Up next, we have Savvy General Trading PLC. Savvy General Trading PLC. Round of applause for them, ladies and gentlemen.
Hello, everyone. I'm here from Addis Ababa University, Ethiopia, and millions of people in our country are faced or struggling by visual and hearing impairment. That's not a scenario or imagination for millions of people in our country. So, in the world, there are many people. It's like, according to World Health Organization, more than 2.2 billion people are living with visual impairment, and more than 430 million people are living with hearing impairment. From that, less than less than 2% are accessing for AI-assistive technology. In our continent, Africa, these are the same thing, like 26 up to 30 million people are living with visual impairment, and 40 up to 50 million are living with hearing impairment. From these, less than 2% are accessing for AI-assistive technologies, and for our country in Ethiopia, 5.4 million people are living with visual impairment, and 3.5 million up to 5 million people are living with hearing impairment. The ratio for accessing AI-assistive technologies are less than 1%. So we saw that there is a technology gap that are existing AI solutions. 80% of existing AI solutions are expensive and non-affordable for majority of the people. That's why we built two systems, one for visual impairment and the other for hearing impairment. This is for visual impairment. This called iPad. It navigates and detecting any objectives, around 100 objectives, 5 up to 10 meters, and object detection, face detection, navigation, and it gives awareness and voice guidance system for visual impairment. The other is a platform that are tracking, that are used for sign language and hearing impairment, that converts sign language to sign language to text, text to sign language, and gives a medical consultation for hearing impairment people. When it comes to market side, the first one is globally. It has 13 billion up to 45 billion worth, and in Africa, these sectors have grown faster, 7 up to 10% are per year, and in Ethiopia, it's initially targeted for schools, partnership with health sectors and government association. And our business models are B2B, B2C, and B2G. B2C like subscription fee around 1 up to $5 per month, and B2B like institutional packaging for healthcare and schools. B2G like governmental partnership. So traction and validation, we are ending with prototype for visual impairment, and we built a software for hearing impairments. This is our team. This is me, financial manager for our team, and my friend Heiner, she's marketing manager, and he is our friend, system developer and strategic innovation leader. So today we ask like $6,000 for hardware improvement and technical R&D and distribution alliance.
Judges?
Great job. I have two questions for you. My first question is around the portability of the device, specifically the one for the visual impairment. How portable is it? So like, because I'm trying to think of the practical use of it when somebody's moving around. And then my second question is, I looked at your team and I don't see anyone who specializes in hardware. There's a financial manager, there's a marketing manager, and there's someone who focuses on AI integration, but there's no one who is sort of like an engineer physically. But it seems like what you're building requires a lot of actual hardware engineering. So how are you looking to plug that gap?
Okay, thank you. The first one is it's a prototype for visual impairment, and it has a night vision during night, and it recognizes an object and detected for that, and it has a voice guidance. If you want to see or check, okay, it detects like when it detects like I see a person in front of you, I see a person like this, I see a person left from the left of you. It gives a direction and it detects measurement. And the second one is a team. He graduated with electromechanical and IT. he both dual purpose for our team.
All right, okay, thank you so much. And I still haven't seen the problem that you're trying to solve and to who. Yes. Those are two questions, the problem that you're solving and to who.
Okay. Our main target is people living with visual impairment and hearing impairment. And starting from any age that can use, like illness or disabilities come suddenly, like by illness or birth or other things, but anyone can adapt these things.
So is your use case so in terms of your business model, is the idea to create these tools and then are you selling directly to consumer? Are you going to target NGOs that work primarily with people with visual or hearing impairment? What is your business model? Are you running this as a social enterprise? Are you running it as a non-profit? Are you running it as a for-profit? What model do you have in mind?
At the plan, we partner with governments, schools, and hospitals. We sell these things, especially a platform for schools, governments, and NGOs. They sold it like a support, other things. Handholding devices are selling by unit sales, like that's a revenue generation.
So have you begun to engage those stakeholders? Are they interested? Have you had any preliminary discussions?
We are not selling, but we tested for 50 individuals. We are testing on the progress, but we are not going to market.
No, I mean, but to like the government, have you taken it as a prototype
Ongoing
and shown
process.
it to the government to say, this is what we are building, if we can do it, will you, are they interested?
Yeah.
Okay. Thank you very much. Savvy General Trading PLC, thank you very much. Up next, we have Metagrade. Metagrade.
Good afternoon, everyone. My name is Kwame. I'm a health entrepreneur and the team lead for Metagrade Limited Company. Today, I'm here to give you reasons to invest in our business. It all began on August 30, 2021. As a herbal and medical student of KNUST, I had the opportunity to do my clinical internship in Kumasi South Hospital. One time in the consulting room, a middle-aged woman walked in with a child, both living with diabetes. During consultation, we discovered that despite repeated warnings, this mother still consumes sugar on a regular basis, and again, fed the child with sugary foods. You can imagine the firm and passionate tone of the doctor on duty as he cautioned her yet again on the dangers of such lifestyle. But in it all, there was a statement made by this woman that struck a chord in me that vibrates even till now. Guess what she said, and I paraphrase. "Oh, doc, I am but only 42 years old, living with such constant pain, weakness, and daily bodily torture. Can't I at least enjoy the sweet taste of the foods I love the most before I die? I would die anyway." That statement did not hit me as a voice of carelessness. To me, it sounded more of the voice of someone exhausted, someone grieving the life she used to have. Statistically speaking, we live with about 598 million people living with diabetes, and they do share in this story. The problem is obvious, people. The reliance on sugar and artificial sweetness contribute to health-related issues such as obesity, high blood sugar, and the likes, primarily affecting diabetics and health-conscious individuals. And the point is, there's a lack of a natural alternative that tastes equally good as sugar without a health compromise. But worry no more, say no more. Oh, say no more. introducing very sweet natural stevia, a plant-based alternative to sugar that tastes equally good, in fact, incredibly sweet, without the health guilt. Now, what makes very sweet special is that it doesn't add to your sugar level, it doesn't add to your blood, your weight. It's also tooth-friendly for these our children, and fully packed with other health benefits. Now, we are primarily targeting the diabetics, health-conscious individuals, but also our revenue stream would also be coming from the B2B, particularly the food and beverage industry, the bakeries and confectionaries, the herbal medicine manufacturers, and many more others. We do have competitors. Now, on the global scale, we are leading the competition with what we call our taste. The unique formula that we have gives us that kind of leverage that our taste is very much unique. You don't taste or very sweet and be thinking about sugar anymore. Very sweet is just incredibly sweet, just replace your sweetening needs. Also, we are leading the price on the market, particularly for the African continent, and also we are the first mover within Africa. So, we have already secured some funding, we have done a lot of works, we have a production unit, we have the product even on pilot, and interestingly enough, right after we did about 100 samples, that was the capacity we could do at the time, we decided to pilot with it, and within just 3 days, in fact less than 3 days, we sold all the 100. Then again, we had to now make some available for this particular presentation. I brought about 15 here, and just yesterday, all of them is gone. The one I played before the judges, they are for someone. Right after here, I must take it. I'm sorry. Now, this shows that there is an incredible demand. There is a demand for this particular sweetener. Not only is it going to help, but also it's going to be a very good, lucrative venture for you as an investor. We have awesome people from diverse backgrounds. We have a legal team, we have a medical team, backing this particular project. So your money is surely safe with us. Then again, we are looking for no, of course not. We are looking for $11,000 to make sure that we get to meet the demand that we are currently facing. With this $11,000, we'll be able to get more packaging materials that we can help to do, that will help us a lot. Then again, we can invest more into digital marketing to be able to dominate that space as well. Now, the whole point is this. With this, in the next 2 years, we are looking at dominating Ghana. In the next 5 years, we are looking at dominating Africa. In the next 10 years, the whole world should look for us. We are the next Nestle coming on board, and I want you to be a part of it. If you want to be a part of Metagrade, I want to say yeah. Thank you very much.
Thank you very much. Judges?
So where is your stevia? Well, first of all, you can't give this one because the pack you gave me was already, it has split open. So your packaging probably needs to be looked at. But anyway, where is your stevia grown?
Awesome. So we currently grow some ourselves, but we can't rely on it right now because of the kind of infrastructure we need to put in place to be able to meet that demand. So we also outsource raw materials from other areas as well.
No, so where?
So we outsource some from Kenya and some from China.
So you are packaging Chinese stevia in Ghana?
Nope, we are not packaging Chinese stevia in Ghana. We import what we call raw materials. Now, regarding the stevia industry, the gospel truth is this. The problem is regarding the bitter aftertaste when it comes to the stevia. The extraction of the sweetness from the stevia plant is generic. Anyone at all can do it. But what makes us special is how that at the end of the day, our taste differs. Now, that taste enhancement thing that we do is what we do here basically in Ghana. And then again, when it comes to the stevia industry as a whole, now the differentiating factor is about your formula. We use a different formula when it comes to how we get to the product finalization. So basically what I'm saying is that we get the raw materials from there. That is to make sure that every plant or whatever time we get there, we extract some here, but because of capacity, we also import some other raw materials that are semi-processed in China. Then we continue the process from here.
So now you see, you started telling me it's not Chinese, but now you're saying it's semi-processed, so it's partly processed in China. The truth, I mean, you claim you want to take over the world, but you are not currently producing your raw material, what percentage of the stevia in these packets is Ghanaian versus Chinese or Kenyan?
Okay, so the ones we have here.
No, I don't mean, I mean in general. What percentage of your product is Ghanaian stevia versus Kenyan stevia versus Chinese stevia?
Right now, we are not yet on the market.
No, I'm saying yes, but you said these are belonging to people. So what percentage of your production is Chinese, Kenyan versus Ghana?
Regarding the raw materials,
Maybe this in the pack right now.
Yeah.
Yeah, just use this pack.
So particularly with this particular product, right? So now with this product, this is how we got it. So now we've grown some here in Ghana during our pilot.
You've told me already. Wait, I just saying you are producing. You are here pitching based on a production.
Yeah.
So I want to know of the total bulk production that you currently do, if it's 1 kilo, 10 kilos, whatever. What percentage of your raw material is Chinese? What percentage of your raw material, or partly processed or whatever it is Kenyan? What percentage is Ghanaian? It's simple.
All right. So with this particular one, we have about 90% of it Ghanaian, and then we have about 10% from China.
And Kenya? You told me you also are from Kenya.
So I was telling you where we are going to be outsourcing our raw materials from.
So right
As
now
it
it's
stands,
China
we are not
and Ghana.
yet on the market. Okay. We are still at the feasibility and then also the piloting phase.
Okay. So Splendor obviously is the number one globally. How are you price competitive with Splendor? Is it simply because Splendor is imported, so you are cheaper in Ghana? But if you want to go global, Splendor obviously has massive distribution. So I'm not quite convinced at this point how your price leadership, as you call it, is going to really allow you to do.
So with the price leadership, is particularly for the African continent, like I earlier mentioned. It is the taste that I was looking at, the global one. Now, when it comes to Ghana particularly, you can get that brand of that imported ones. The minimum, ours is 100 gram. The minimum that the minimum price for a 50 gram in Ghana is 70 cedis. Ours is 100 gram, yet we price it at 30 cedis. So you can imagine the kind of price difference that we have here and how that we are going to lead the competition in Ghana and in other African countries.
Okay, thank you so much. My question is around the roadmap. If you can go there, on that slide of the roadmap. I see the first few months is concentrated a lot on the marketing of the product. Yes. So which is almost the same, all the way month 1 to month 11 is almost the same thing, of which, in my opinion, you're asking for how much?
$11,000.
$11,000. And so that will take a lot, of which it should be concentrated in having that product, perfecting it, to go to the market. And once that product is perfected, then it means you do not need all that from month 1 to 11. It will sell itself. Thank you.
Sure.
So my quick question, I'm a skeptic, honestly speaking. Like, I was a sales guy too, so I know how to sell products to make it believable. But I truly believe that everything has a downside to some degree. So be honest with me. With your stevia product, what are the effects of excesses of it? Like, I need to understand that perfectly. I can't believe that this is the holy grail of sweeteners on the screen. So I'm a skeptic. Convince me that this is actually good, and tell me the truth. Like, what are the detrimental effects of this in excess as well?
All right, so thank you very much. So we have done...
And what trials have you done?
All right, so we have done animal studies on this one. In fact, literature confirms that stevia is not toxic to the body, particularly even in high amounts of doses. And so we did a test to confirm that. We actually did what we call a toxicology study in K University, also repeated the same thing in CPMR, Center for Plant Medicine Research. That was about 2 years ago, after we were able to get our prototypes. And then after we did that, we realized that even with high doses, the animals were very active and alive. Now, the only thing about our product is that our product is not meant for those that are let's say, how do you call it? Those that are low on sugar. Okay, so let's say for someone that is looking for energy, maybe the person is low on sugar at the time, hypoglycemic, and is looking for sugar or energy. our product is not recommended because our product contains no sugar, it contains no energy inside. Yes.
Thank you very much. Thank you very much. Shall we give a round of applause to Metagrade? Ladies and gentlemen, just a quick announcement. I would like to beg that we minimize the conversations in the audience so that we can all focus on the presentations so that the judges can also judge without any distractions. Up next, we have Micro Innovate Hub. Micro Innovate Hub. Round of applause for Micro Innovate Hub.
Hello, good afternoon. Today, we are on a pitching session looking for which idea to fund. I came to present to you the future of Africa. The future of Africa in terms of healthcare, biomedical devices in our labs. We have so many hospitals in Africa, so many of them in Ghana. But the question is, do these hospitals qualify to indeed be a hospital? Do these hospitals have what it takes to be able to make a conclusion that this person has malaria or tuberculosis or this person has this other thing, right? So it is in us to think and to realize that there's a gap in our healthcare when it comes to biomedical devices. There are only a select few big hospitals, I can name one, like UGMC, University of Ghana Medical Center, where you find most of the equipment, ultramodern ones. But 95%, as documented by WHO, shows that 95% of all of our hospitals in Ghana lack the essential medical equipment, such as microscopes, and then all that you need to be able to make a diagnosis. So in most instances, you find medical officers guessing what the diagnosis is. And a guess is not a diagnosis. From a biochemistry perspective, we know that you cannot just base on one or two and say that I have diagnosed this person. That was a thing of the past. Now, we have brought on board laboratory testing. That is what biochemists sought to bring. So the fathers of biochemistry brought all of these tests that we need to run to be able to confirm, run a series of tests to confirm that this person has malaria. But if you go to a hospital in a rural area where these things are not there, we cannot do them. We just guess. And it leads to a lot of global health problems, and we keep on spending money to do research into antimicrobial resistance and all of these things, not knowing that the problem is that we do not have essential medical equipment in our labs to be able to make correct diagnosis. All right, so this is what we want to bring on board. My name is Jacob Nahuankese, and as the founder of Micro Innovate Hub, what we sought to bring is a solution to this gap, lack of essential medical equipment in 95% of Ghanaian hospitals and 1/3 of Africa's hospitals. All right, so I think I have to use this. So we want to become Ghana's first biomedical manufacturing platform. And we want to start with an open flagship microscope, an open source, open flagship microscope that allows us to be able, that allows us to adapt its components and make for feasibility of our people. Now, the uniqueness of this is that it is affordable. It's 60% more affordable than the standard one, and it performs almost at the same level. So there's no point if you have this and you're competing with Zeiss or Olympus. If you have this in your hospital, you can make accurate diagnosis, malaria diagnosis, and any other diagnosis. So I'm not just saying this. WHO has confirmed that this, in 2024, it confirmed that this technology is a great one, and it's one that we should look into. So we are not starting from zero. We have built a prototype from KNUST certification. They gave us 18,000 Ghana cedis to build a prototype, which we have done. and it's working. We've tested it in some of the labs, and it's working. Now we have secured some amount of money to continue. We are still waiting for it to be deployed. So now, this microscope sells at $2,839, and the cost price is $2,357. So the profit we are making is $482, and you can see the price is very, very low, right? Now, we are asking for 220,000 Ghana cedis, not on this pitch platform, but to say that this is the amount of money we need to get going into the market. But we have secured an amount of $8,500. So what we need now is 118,000 Ghana cedis to complete the amount that we need as a seed to be able to go into the market and get into the 95% of rural areas. This is a team that builds. Myself and my colleagues in different areas, technical field, and in the research area, and the marketing area, we build this microscope. And we are looking forward to selling it to the rural areas. Thank you so very much.
Thank you very much. Judges?
Great work. I'm worried that my question might seem a bit ignorant, but from what I understand you're doing is that you're 3D printing medical equipment. That doesn't seem so revolutionary in my head. Like, I'm wondering what's stopping somebody else from doing exactly the same thing. I'm also wondering, like, I would be surprised if there are no other 3D printing manufacturing plants in Ghana. It just seems it doesn't seem that not commonplace is what I'm trying to say. So maybe educate me a little bit. There might be something I'm not seeing in what you're doing because I don't see the real differentiation or what's stopping somebody else from easily doing this.
Okay. Thank you very much for the question. So 3D, it's something that anybody can use to do anything, but to fill a space is something else. You can always use 3D to do anything, like prosthetics and any other thing. But the point of entrepreneurship, in my view, is that who takes the step to fill the gap? Of course, there may be others who may want to compete, but the point is who is leading the journey. Some people will not lead the journey except you start. They begin to learn from you. But for someone to probably replicate this, we are not just focusing on open flagship microscopes. As I mentioned, we are focusing on biomedical devices. And so we are targeting a range of devices from pipettes, centrifuge racks, and all of that. But using a 3D is not just for the fact that anybody else can replicate, but in a sense that it fits our context where we are. We are in Africa, and sometimes it's best if we look at the things that best suit us and are eco-friendly to us, instead of just having import of sometimes equipment which have already been used, and they just brought them to dump on our continent.
Yes, but another Ghanaian can do exactly the same thing, is what I'm saying. Like, and I get your point on first mover advantage, but a lot of first movers have failed compared to those who came after them because they learned from their mistakes. So that's what I'm trying to understand is, yes, you have the first mover advantage, but another Ghanaian could easily replicate. So is there someone on your team, is there something I'm not seeing that really makes you guys the guys that would stand out and not be, because like I said, I think a 3D printer can be, unless I'm wrong, right? I think a 3D printer, getting access to that, getting access to the specs, it doesn't seem that complicated.
Yes, so that is why we are not just, so first mover, but we are not just selling microscopes. We are dealing in other biomedical devices. So the fact that you are able to replicate this maybe after 5 years doesn't, in a way, bring our market down, because by that time we may have gotten what we wanted and have moved on in different areas of our market.
Can I go? I was just going to follow on from his question. No, I think what his point is, Open Flexure is open source. Yeah. I can download it today, and I can 3D print it if I know how to 3D print tomorrow. So it's not 5 years, right? So you have a significant issue because you don't own the IP upon which your microscope is built. So it's not your innovation. So it's nice what you've done, but anybody could do it tomorrow, and if they had more money than you, they could mass produce. And so I think that's something you need to think about. My question actually was regulatory. Who regulates 3D printed lab equipment in Ghana? And because if they use it and something happens, who bears the liability?
Okay, so the regulation has to do with Ghana Standard Authority. So we are looking forward to having a talk with them and then getting certified. We can start.
National who?
Ghana Standards Authority.
Yes, so just a little feedback. I think you spent almost 3 minutes doing a high level going around about, lack of health care access in Africa and in Ghana. So it wasn't really clear at the end exactly what is your unique proposition, value proposition for this, and who's your target? I know you spoke about rural areas. So you're building these technologies for them. Are you thinking about capacity from a human resource point of view? Is this like an integrated solution that you're building? I think that was lost because you had to rush through the last couple of minutes you had. So it's not really clear how unique this is and how the solution will help to improve healthcare, which is what you're trying to do, correct? Yeah.
So the first thing is that it's less expensive, and then it can be it's affordable in our continent where we find ourselves. So the first unique advantage is that it's affordable, and as compared to the conventional microscope, it provides almost the same quality as a microscope that is sold at 30,000 Ghana cedis. And so it becomes no point for you to go in for that if you can have this doing almost the same job. So that is what we are looking at, serving it to the rural areas where they don't even have those ones to work with. Yeah.
Thank you very much. Round of applause for them, ladies and gentlemen. Ladies and gentlemen, we are halfway through the pitches, but I can sense that majority of you are tired. I'm tired too. So here's what we are going to do. 3 minutes break, get up, stretch, go to the washroom, have some conversations. We'll be back here in 3 minutes. 3 minutes exactly. Thank you very much. All right, ladies and gentlemen, 3 minutes is up. Let's take our seats. 3 minutes is up. Shall we take our seats? Judges, please take your seats. Audience, take your seats as well. Thank you very much. Ladies and gentlemen, the next venture that we have on stage right now is Seizure Guard. Seizure Guard. Shall we give them a round of applause? Seizure Guard.
Good afternoon. My name is Asada Boasmach-Nebo-Akodia. I am the founder and venture lead of Seizure Guard. I'm a final year biomedical engineering student at KNUST. I'm also a recipient of an innovative grant from the African Health Collaborative. I would like to tell you about a woman named Madam Agi. She was a primary school teacher who impacted the lives of so many students, mine inclusive. One Monday morning during a general assembly, Madam Agi suffered a seizure in front of the whole school. Unfortunately, after that incident, she didn't come back to school again to teach us. At the time, I was very young and I could not understand what exactly the problem was. Could it have been fear? Could it have been the feeling of loss of control of her own body? Could it have been the embarrassment of the incident? Unfortunately, worldwide, 50 million plus people are suffering from epilepsy, and 80% of those individuals live in low income and middle income setting like Ghana. In Africa alone, we have 10 million plus people with epilepsy. People with epilepsy suffer the crisis of uncertainty, not knowing when exactly the next seizure is going to come, living in constant fear. There is also a social and cultural stigma attached to these people that live with epilepsy. And there is also a monitoring gap where they don't have the means to be monitored continuously to be able to predict when the next seizure is going to occur. This is where Seizure Guard comes in. Seizure Guard is a wearable EEG-enabled cap that is going to continuously monitor the brain activity of patients, give them real-time predictions of their seizures, and also give emergency alerts to the patients themselves and their caregivers. This is an AI mock-up of how the device would look. This is how we wish it looks like. It is enabled with specialized dry EEG electrodes, as you can see in the image there. This is the device in use and the dashboard of the mobile application that will be used by the patients and their caregiver. This is also an alternate design concept that we have so the patients would have options to choose from. Seizure Guard stands tall amongst hospital, EEG, and other wearable devices in the areas of continuous brain monitoring, AI seizure prediction, and non-clinical setting use. Projecting into the future, we have 50 million potential users, including people living with epilepsy, their caregivers, hospitals, and neurologists. So far, we have been able to secure a $10,000 US grant from the African Health Collaborative. We have initiated our patent filing. We have registered our business. And what is in progress is the building of the architectural design of our hardware. And we are also trying to develop our personalized EEG electrodes. And we are in the development of the architecture of our AI. The next steps, we are looking to partner with neurologists, patients, and we are also seeking that you fund us with $10,000 US to pilot the prototype development and also go on with the pilot testing. This is my team. That is myself and my team members. I'm a biomedical engineering student, as well, and there's also a computer engineering student on the team. Ladies and gentlemen, this is Seizure Guard. Thank you.
Thank you very much, judges.
Thank you. Thank you for your presentation. I'm just checking with, practicability of wearing the hat, because it's both of the designs you showed are hats, right? So I'm wearing my kaba and then I put on my hat, or how does it work? And we all know that, you know, with seizures, if you're gonna have a seizure, you don't know when it's gonna come. A lot of patients have it whilst they're sleeping. They can't really wear that to sleep. So yeah, just checking how practical is this. Great concept, but yeah.
The design concept was actually informed by what we have in mind. There's a stigma attached to people that have epilepsy in general. And the devices that exist are bulky, and the ones the hospitals do have wires around them, and they cannot even be used in real life setting. It's confined in the hospitals. Our design is embedded with claw electrodes that will be able to penetrate the scalp. And for people that work in corporate spaces, they can't wear the caps to their workplaces. So if the cap is worn for a maximum of 24 hours, it is going to get adequate data to be able to predict your seizures during that day, for, let's say, 8 hours for when you are not going to wear the cap. So if you don't want to wear the cap for this event, and you have worn the cap yesterday, yesterday's data can be able to predict your seizure for today.
Yeah, and you know that most patients with you know, seizure disorders, if they are on medication, it's very rare for them to have a seizure, right? So I hope you think about that whilst you're doing your design. Once you're on medication and you're compliant on your medication, the probability of you getting a seizure is quite low. Yeah.
Thank you very much.
Yeah, you said you'd filed a patent, so I'm interested in that. What does a patent cover? And are there any other caps like this? I mean, how novel is this? Are there others on the market? I know the ones we've seen in hospitals that you often see also in movies, but I'm wondering, is there a more ambulatory wearable solution that exists on the market somewhere? And how does your patent distinguish, like, yeah?
Thank you very much. The ones on the market do not rely on EEG. They rely on symptoms of your body, heart rates, and then muscular changes. But we are harvesting signals directly from your brain to be able to predict your seizures.
So what does the patent cover?
The patent covers the hardware development, the signal processing techniques that we are going to incorporate in our device, and it also covers the AI architecture that we are developing.
Okay, so, but how does that differ from, because there are EEG caps available, right? So is it just that you've taken that design and now put it in a baseball cap? Or are these sensors fundamentally different from the ones that come in the hospital ones?
Yes, please, they do. They are different from those ones.
My question is around your revenue model. I haven't seen it, I think, or maybe I missed it. But how do you plan on going to the market, taking into consideration what you have been asked before about what is different about your product?
Thank you very much. We are looking to partner with neurologists and healthcare professionals. Patients trust their doctors, so our first point of communication with the patients would be through these doctors. And after selling a unit, we plan to have a premium version of the application so they can access certain very imperative features. So that is the way we plan to generate revenue.
Thank you very much. Thank you very much. Let's give a round of applause to Seizure Guard. Thank you very much. Up next, we have Snoocode Red Limited. Snoocode Red Limited. Shall we welcome them?
Hello? Okay. Are we ready? Good afternoon, everyone. What you have on your screen here is a set of calls that I received on the 30th of July, 2022. They were from my uncle. His wife needed an ambulance, and he couldn't reach them. I had done a lot of work with the ambulance service, and so he wanted me to help. I was asleep, and in the end, she died. Okay. So my name is Sesnam Dagadu, but for the remainder of this presentation, I will have to insist that you think of me as a mid-30s, very accomplished mother of two, Dr. Nana Sawakwa. She is our CEO for Stick Red. 9% of sub-Saharan Africa, okay, yeah, 9% of sub-Saharan Africa has no access to formal emergency services. So 91% of us, if we had an emergency, would be in a lot of trouble. 40% of health spending infrastructure is also lost due to inefficiencies. So this is an example. Giwon, he's an ambulance driver in Sierra Leone. He cannot find any of his patients because they do not have an addressing system. So we built one, and we built a navigation system that works even when you're offline. Dr. Kwao, me, works in the emergency room. She receives lots of patients, she's overworked, and by the end of the day, she's really struggling to make good decisions. So we built a decision support system that allows her to give the best quality of care to all her patients. Moses is the only healthcare practitioner in his village, and a lot of times he needs access to information that he doesn't have. Again, the same decision support tool is able to help in that situation as well. And Stephen is a policymaker. He advises the governments on where to spend the little money that they have on hospitals and pharmacies and CHIPS compounds. We built a system that allows him to segment the country and have very, very granular data as to who needs what and where. So, a navigation system, an ambulance response system, decision support, and navigation that allows you to work by air, land, and sea, offline. We've built technologies that allow all of these things to work together. And these are all the components of our offline system. So we're building components that can be white labeled by anyone to build anything that they need to in healthcare. We've also built some really impressive maps as to healthcare access, right? So if you're in the red area, you're over 3 hours away from healthcare. If you're in the blue area, you're closer. The idea of all the technologies we build are to have better targeted planning, optimized resources, improved accessibility, and all of this adds up to improve patient outcomes. So this is an example. In this one of the constituencies in Ghana. The people in area B are far away from a hospital, but they have good roads, so they are only 15 minutes away from a hospital. The people in area A are close to a better hospital, which is a primary hospital, but because they don't have good roads, they're 45 minutes away. The people in area C have too many hospitals, if you can believe it, and the people in area D do not. This is what we visualize so that people can make decisions in a much, much better way. So Africa's digital health market is around 6 billion. We are targeting about 315 million of that. It seems very aggressive, but I hope by the end of this you will agree with us that it's achievable. So we do this through partnerships. In the last 18 months, we've taken 125,000 in revenue with two main customers, LFR, which extends our reach into 5 countries, and UNICEF, which we've done a lot of work with in Zimbabwe. In the next 2 years, we're looking at 2 main countries, Zambia and Uganda, and we've reached agreements for for an annual taking in of $720,000 for Uganda, and a one-time of $610,000 for Zambia. We are looking to raise $540,000 to reach more countries, so 5 more countries over the next few years. As you can see, the majority of that is spent on business.
Thank you very much, Snookode. Thank you very much. Thank you. Round of applause for Snookode. Judges.
Thank you very much. And I mean, Cessna, we've spoken a lot this week already regarding your business, but for the sake of the other judges, could you explain, so the understanding you're building a system to support emergency response. Are you just providing the governments or the healthcare institutions with the system to feed their own data in, or are you providing them with the system and the data? Which of the two? And if the data, you're providing the data, could you walk us through how you are gathering that data as well?
So we do both. So we have a baseline amount of data that we provide to countries. So right now, the densest data set we have is for Ghana. So for Ghana, for example, we know where every village and town is. We have 10,000 segmentations of the country. We know how many women, children, how many 5-year-olds, how many 18-year-olds at every part of Ghana, and how close they are to every kind of health facility, whether it's a hospital, pharmacy, and stuff like that. The government can then add more, more data to that. So that's how we do it. We derived our data using lots of methods. I started off doing digital forensics for the British police, so we have really good methods to deliver that sort of thing, which we can talk about on stage. But we're happy to talk about. I'm happy to talk about it if we have NDAs signed. But we have very granular data. I dare say we have better data than the Statistical Service of Ghana. We have the data to prove it. Yeah, so that's that.
So just to understand, so I mean, yeah, the maps look really cool. You just said you have better. So how many years, I mean, what's the journey? I mean, obviously Snookode right now has gone through. So how much did it cost to build up such a database? What agreements do you have with the government to allow you to possess better data than they do? And then going forward, I'm assuming you don't have as good mapping in every country. So as you think about Uganda and these other places, how strong is the data? Because your products are really built upon understanding the local lay of the land. So where are you going with that?
Okay, so 2 things. So Snookode Red is a spin-off from Snookode. Snookode is a long-established company. We built systems to deliver, parcels and pizzas, I like to say. And we eventually came across the idea that the same technology that can deliver parcels can deliver an ambulance, right? So that's Snookode Red and everything that follows from that. So that's one. So Snookode Red has a huge advantage because a lot of the research and development was already done. Now, in terms of the collection of the data, in the last 18 months, we've spent over $250,000. And for that, we have very granular data for Ghana, Nigeria, Kenya, Zambia, Zimbabwe, I'm missing one other, and a few other countries. Now, if you think about it, UNICEF told us that it would take them about $400,000 to do Ghana alone. And we told them that we could do it, and we did it for under $37,000, right? And so on the back of that, UNICEF said, okay, if you can do it, there's this project that we were looking to cancel because of funding cuts, but if you can do it, we'll pay you $50,000 to do Zimbabwe. And we did it. We are able to share that with you as well. And they've given us permission to share that with you.
I have a question on, you have been in operation for some time, right?
Okay. Well, yes and no. So Snookode has been in operation for a long time. Snookode Red as an entity is only about 2 years old.
Okay, so what challenges have you encountered and what do you plan for it for future?
Okay, I think the first challenge, and the people who know us know this, working with African governments is character building, to say the least. It's extremely challenging. And so we've ended up developing situations where we go out and do the work, and then we say, okay, if you want it, pay for it. Working together with African government is so difficult that we just don't do it, right? And so we have a finished product, and if they want it, they can work with us. And I think that's that. That's a major challenge. Funding has also been really good, but fortunately, we've not had as much difficulty as other people. I think that's that.
Can I ask?
Yeah.
Yes, you can. Yes.
So currently, it means you're not in operation with any government. I'm asking because, I mean, you know about Ghana and our ambulance service. It's basically a scoop and run, right? They scoop the patient and they run to wherever without knowing where they're going, where there are beds, where there's infrastructure. And this technology would be a game changer from an emergency management point of view. So I just want to understand, I got what you said about working with African governments, but is there any, what's your goal? Let's use Ghana as an example, because the need is great.
Okay, so there are two things. And so one, Ghana already has a national addressing system. We don't market into Ghana because it's dangerous. If people now have our addressing system, they try to call an ambulance, then the ambulance service is using a different one, people might die, so we just don't do it. But through our partners, the LFR, we are working with 5 different governments, including Nigeria and Kenya. And yeah, they are working, they are obviously more successful with working with the governments than we are. So they white label our products across the region. But yeah, we really need to have a conversation after this. Thank you.
Thank you very much, Snoop Boat, Red Limited. Up next, we have Rise Beyond Organization. Rise Beyond Organization.
During my clinical internship, I met a child with cerebral palsy. She has been at the hospital for 4 months. This child was suffering from a condition that needs continuous rehabilitation. And it's not only this child called Divine, but a lot has been suffering from this. And why now? We have conducted research in one hospital we have partnered with, and we have seen that 75, there is mobile penetration, and also we have few rehabilitation professionals that are serving 14 million people, and we need to act very quickly. Rise Beyond is a mobile application that extends rehabilitation beyond hospital into homes, because these children do not need to rest at the hospital, but they just have to live as others. And also, caregivers, they need to go back to work as well as to care for their children. We are helping them to get the solution through our mobile application. We are helping them also to give them the community health workers who will be supporting them at home. And also this is coming as empowerment, as we are providing assistive technologies to them. This is our product. We are targeting hospitals. We are getting our kids from the hospital, and then we onboard on our system. And then we do the assessment. We give them personalized rehabilitation. We give them trained community worker. We give them assistive device packet press. This is a complete rehabilitation pathway. We are not actually giving them to follow exercises or communication only, but we are completing everything that they need. Our business model, we are targeting NGOs and donors. We are targeting insurance.
middle class and upper class subscriptions, assistive device marketplace. And why are we targeting this? Because we are reducing the costs that has been made to these children. Again, we are helping insurances also to reduce the costs. And you know what, for the hospitals, we are increasing efficiency because we are allowing new admissions for the hospitals because we are taking these children into homes. And for the caregivers, imagine you have a child and you have a work accomplishment and you need to be at the work. So we are giving them time as well as reducing their cost of the transportation. Our market is this. Globally, we have 46 billion, and we are targeting 3 to 8 billion in Rwanda. The competition is Rise Beyond is giving complete rehabilitation pathway. This time, currently, it is hospital-based, but now we are moving from the hospital into the communities. Our traction, we have done partnership with University of Rwanda to do a clinical background research. What I'm talking about, this is the experience that I got from the hospital, and I have done, well, the needs assessment, and what we are giving them is what they asked for. And we have engaged 10 caregivers for physiotherapists, 3K funding we have secured 3K funding for us to build the research and also the prototype. We also certified in Finland. We have certified in disability inclusion, and what we are doing is backed by that. The ask today is 10,000 USD. This is phased in 2 phases. For the phase 1, we want MVP completion for 5,000, and phase 2 for 5,000, we want to be the pilot. Thank you so much.
Thank you so much, Rise Beyond Organization. Judges?
Sorry. I'm trying to understand the full scope of the solution you're offering. It seems like you have a blend of software in there with recommendations, but also assisting with locating the caregiver, and then also some local assistive devices as well. But in your current scope of the project, you're still in the MVP phase. So I'm just trying to understand, like, in its full completion, walk me through what exactly this would do. So it's like, is it just recommending activities for people who need rehab support, for kids who need rehab support when they leave the hospitals? Or are you going beyond that? How are you going beyond that? How are you getting the partnerships with the local care workers that will assist? How are you getting the physical assistive devices? I'm trying to just understand the full scope of what you're building.
Thank you so much for the great question. How we are going to work, we are getting our patients from the hospitals. We partner with the hospitals, the NGOs who already have these kids with disabilities. And after that, we onboard our patients after knowing all the assessment. From there, from knowing what they need, we'll be able to give them exercises. And that's why I'm saying it's complete, because we are connecting them to the caregivers who are in their community. Currently in Rwanda, government of Rwanda gives every village a community health worker. And this community health worker, we are partnering with them so that they can help them. And for the assistive local devices, that's where we came in as different from what is in existence. We are helping them to now get very affordable, locally made assistive devices. So we are not actually giving them a partial solution. That's what we want to give, a complete rehabilitation pathway. Thank you.
So do you have a partnership with a device manufacturer? Who are the ones making these local assistive devices? Do you have,
One of our team members is P&O, prosthetics and orthotics, and he is already now in that career. So once we have this this mobile application, then he will be able to connect us with the companies that are doing that. So after getting what the child needs, then we are able to make whatever he needs in locally made things. Thank you.
Yeah. I know there are different kinds of rehabilitation. So what form of rehabilitation are you looking at?
I'm a physiotherapist. We are giving physical therapy rehabilitation, but this is coming with community caregiver empowerment as well as the assistive device. So we are doing multidisciplinary work so that a patient can be able to receive all kind of support he needs. But kindly, rehabilitation is a lot of things. As a physiotherapist, I don't just focus on physical things, but I focus on whatever patient needs. That's why we consider different parts. Thank you.
All right, thank you very much.
Thank
Round
you.
of applause for Rise Beyond. Up next, we have Staying Smart. Staying Smart. Shall we welcome them, Staying Smart?
Imagine taking your father to the hospital to have him tested and you have to wait an hour. My name is Aoma Yunis, founder of Staying Smart Innovations. Good afternoon. When I took Grandpa for TB testing, we waited 14 days for his results. But unfortunately, TB was not waiting. He grew weaker each day and I asked myself, why should diagnosis take this long? Ladies and gentlemen, did you know that over 80% cases of delayed diagnosis in Uganda is as a result of hospital delays? These are not just statistics. These are patients waiting for answers. TB, like many other diseases, is diagnosed by slide staining. Across laboratories in Africa, lab technicians still manually dip samples into staining and rinsing solution, one slide at a time. Yet they're working on hundreds of samples per day. This overworks lab staff, increases the risk of human error and long turnaround time. Existing stainers are very expensive, require high maintenance, and sometimes even the spares are hard to find. If delayed diagnosis is a problem, then manual slide staining is the bottleneck, and we are the solution. Last, the fully automated slide stainer that is affordable, low maintenance, and can support up to 30 slides per cycle. It is versatile, performing tests on several diseases, and can be powered by both electricity and battery. We've raised so far $11,000 in seed funding, conducted prototype development, and user testing at expert laboratories. Feedback from this was integrated as we build a minimum viable product. We've signed an MOU with Lera Electronics to further refine our product and ensure local production here in Africa. While existing automated stainers are consistent, they are very expensive. Manual staining, on the other hand, while affordable, lacks the consistency, scalability, and advanced diagnostic. Last standardizes laboratory workflow across laboratories. It integrates multi-disease testing, affordable, and it is locally made here in Africa for Africans. Across Africa, South Asia, and Southeast Asia, over 150,000 laboratories still perform microscopic diagnostic, giving us a total available market of 600 million US dollars and serviceable available market of 452 million US dollars. Initial deployment will focus in East Africa, giving us a serviceable obtainable market of 18 million US dollars, and we believe within the first 5 years of operation, we'll have captured 10% of the SOM, targeting customers like hospitals and laboratories, research and academic institutions, and mobile clinics. Last is a commercially viable product that integrates multiple revenue streams like direct sales, installation, repair and maintenance, and sales of spare parts. Our go-to-market strategy follows a three-step process. One, we enter laboratories through pilot and demonstration, targeting early adopters, and all these we have already done. Once we've proven these through cost savings and improved efficiency, we believe these will convert into contracts and scale through case studies, partnerships, and conferences. We are seeking 250,000 US dollars in seed funding for clinical validation, design optimization, and regulatory readiness and commercialization. We have already gotten a letter of intent to do our clinical trials at expert laboratories and bi-regional referral hospital. Next, we conduct business development, seek regulatory approval, launch our product into the market. We are a multidisciplinary team from biomedical, mechanical, electrical, and advisors from medical laboratory and business. Partner with StainSmart Innovations today, and let's reduce the weight, the disease burden, and most importantly, save lives. These are our contacts. I'm going to show a demonstration of how the machine works. So after it has been powered, the lab person can select a number of tests and load here up to 30 slides at once. So he selects the test. For example, if I want to do malaria thick, and then start. So it dips them sequentially into each of those reagent containers as programmed. So it does that. When it is done, it goes back to the start position. Thank you.
Thank you very much, StainSmart Innovations. Judges.
So thank you for an interesting presentation. Who owns, so is this your own design? Is it an open source design that you have adopted? Who owns the intellectual property for your device?
We own it.
So have you registered it? Do you have a patent?
We have not yet, but we have already drafted the claims that we want to have for our innovation. And we didn't have like a legal person to consult, but since now I'm part of H2I, I have like a legal person who can help me to clearly state out what I need to put out in my intellectual property, but we own it as per now.
Well, you don't own it, so you have the patent, but yeah.
Yes, thank you.
So who designed it? Was it, I know you said you had proto development and all of that. What inspired the design, or was it someone else? I'm just curious. What inspired you with this particular design?
Yeah, so during the prototype development, we had a rectangular version, which was about 80 centimeters by, I think, 45. And when we took that, so when we did the user testing, it was mainly a feasibility and acceptability testing. Can the users interact with our machine without having any blood or what? So we went to a private laboratory, and usually private laboratories have like small clinics. So they were like, this is taking over all of our space. And so we went back and we were like, can we have a system that can do exactly what they want, but just change the modular design, change how it looks so that it can do the same work? So that's why we changed to this.
Just final question. How does this differ in design from the commercially available automated stainers that, as you said, you said they're expensive, but they exist? How does your design differ fundamentally from those?
So for the design element is that it is contextualized to our environment. That is one. It is the materials that we use, we can access them from here. So if I buy a material from Uganda or in Africa, I do not, in case a part fails, then I do not need to wait for someone to come from Germany to come and fix that part. So the design concept is conceptualized for this setting, and I hope I've just answered the question.
Thank you, thank you. Great
the questions look easier when you're there. Okay.
You're doing well, you're doing well, you're doing well. I'm going to put on my investor hat for a second, just for a second. You're asking for 250,000 USD, but you don't plan to go to market until 2028. As an investor, why should I give you 250,000 USD today if I can't even know if your product will be making money until about 2028, 2029?
Yeah.
Convince me.
Thank you. Yes, so, you know, as a medical device, the regulatory pathway is quite long. So I've given myself that period. But during that period, the process, the steps I'm taking to get there, for example, I said I am de-risking by seeking international regulatory approval so that the healthcare workers in Africa do not resist my device. I'm conducting pilots. The process I'm taking to get myself there will ensure that when I get there, I am actually there. I do not back down. So those are the things I'm doing. I'm taking my steps. I'm not going to rush to release my product in 2027, but I'm going to take the steps, seek the approval, do the pilots, make sure the data matches what the population needs, what the healthcare workers need. Yeah, thank you.
I've heard you say I a lot. Is this a team, or is this design centered on you as a person? And if you're not there anymore, what happens to this project and the sustainability of it? Because all I hear is I the whole time.
Seems I'm the only one here. Any Ugandan? Good. So I want to just let you know that in 2024, I was pregnant. That was when this machine was developed. I was not there. So as much as I'm saying I'm not talking about me. There are people right behind me. You're not seeing them, but they are currently watching. So I'm not working alone. Even the partnerships that I've signed, you've seen I'm not working alone.
Yeah, I think the only comment I'll make is you need to file, your first priority should be your patent. Without that, going to market would be very dangerous because I'm assuming others could reverse engineering it. So you need to protect your IP as one of the first priorities before you do anything else.
Thank you very much. Ladies and gentlemen, we have our last venture. And our last venture representative is French. And so he'll have an interpreter. And for that reason, we'll give him 8 minutes to cater for the delays. So let's welcome Karanj. Karanj is the next venture. A round of applause for Karanj.
Au moment où nous sommes ici pour travailler, il y a nos médecins qui sont en train de souffrir.
While we are here working, there are medical doctors who are suffering.
Je vais vous laisser visualiser la vidéo avec moi.
I have a video to play to show. Cette vidéo montre que nous avons solutionné un problème réel. This video shows a very real problem with which we deal. Donc, plus de 84 500 de nos professionnels de santé souffrent d'hépatite B, d'hépatite C et le VIH. About 84,500 of our medical professionals suffer from hepatitis B, C, and HIV/AIDS.
Et cela est dû à la mauvaise gestion des déchets biomédicaux.
And this as a result of poor management of medical waste.
Donc, nous vivons au Sénégal, un pays moins développé.
I come from Senegal, a developing country,
qui est capable de générer plus de 25 000 tonnes de déchets biomédicaux chaque année.
that is able to produce about 25,000 tons of medical waste each year.
Et seuls les 600 sont bien traités, soit 2,4%.
And out of these 25,000 tons, about just 600 tons are properly handled, treated.
Et aussi, nos femmes de ménage souffrent.
And our medical cleaners are also exposed to that.
Et le marché, nous avons adopté le modèle Tam Sam Som. Et pour le marché et l'opportunité, nous avons adopté le modèle Tam Sam Som. Et pour le Sénégal, la taille du marché est 2,5 milliards.
In Senegal, our market size is about.
Donc, pour gagner ce marché, nous avons adopté une solution efficace et durable. Donc, la taille du marché est 2,5 milliards de francs CFA.
So in Senegal, the market size is about 2.5 billion CFA.
Et pour gagner ce marché, nous allons adopter une solution efficace.
And to win this market, our solution is effective.
Donc, c'est une poubelle intelligente orientée dans le domaine médical.
And it is a smart bin that is targeted at medical professionals and institutions.
La poubelle fait un tri de manière automatique.
The bin sorts out the waste automatically.
Avec l'intégration des lampes UV qui tuent les virus en temps réel.
And it has inbuilt UV light that is also used to kill microbes.
Et une plateforme web qui va nous permettre de visualiser le niveau de remplissage de chaque poubelle dans les hôpitaux.
And we have a web platform that is also to help us visualize how full each compartment in the bin is.
Et voici notre prototype.
So this is our prototype.
Et pour nos cibles, et pour l'analyse concurrentielle, c'est ce que nous avons et les autres n'ont pas.
So for our competitive analysis, this is what we have and what the others don't have.
Nous avons des lampes UV,
We have the UV light,
un tri automatique,
an automatic sorting system.
des lampes UV,
We have sensors,
des LIA
AI integrated,
et des capteurs IoT. Et pour notre cible,
and for our target,
pour la proposition de valeur, le tri automatique et l'intégration d'une lampe UV dans la machine.
for our value proposition, we are proposing the automatic waste, the disinfectation of the waste.
Et la réduction significative des risques d'infection.
Reduction of exposure to infections.
Et la revalorisation des déchets biomédicaux mais plastiques.
And potential of recycling biomedical waste.
Donc pour nos cibles, ce sont les districts sanitaires de santé, les universités et les ONG.
So our target is district hospitals, universities, and NGOs.
Et pour la modèle économique, nous travaillons sur le B2B et le B2G.
So we are adopting a B2B and B2G.
Et pour la prix unitaire, c'est 550 000. Pour la prix unitaire, c'est 550 000.
So the unit cost is about 55,000 CFA, 550,000 CFA.
Et pour la location, c'est 23 000 par mois.
And renting it is about 53,000 CFA.
Et la
month.
maintenance à 29 500 par 6 mois.
And maintenance is about 29,000, close to 30,000 CFA per month, per 6 months.
Pour les stratégies go-to-market,
So for the go-to-market strategy,
à court terme, installation de 7 poubelles dans les hôpitaux de niveau 1 et niveau 2.
So we are looking at installing about 7 bins, such bins in level 1 and 2 hospitals in Dakar, in Niger, in Senegal.
À moyen terme, déploiement de 30 poubelles dans les cliniques et les universités de niveau 2 et niveau 3.
Medium-term goals is to have about 30 such bins in clinics, universities, and other higher-level hospitals.
À long terme, expansion progressive vers le reste du Sénégal, puis en Afrique et dans le monde.
And long-term goals is to expand across Senegal and Africa and the world as a whole.
Donc pour l'attraction,
so for attraction,
5 médecins ont testé.
5 doctors have tested the bin.
9 techniciens ont testé.
9 technicians have tested it.
Et aussi 2 hôpitaux, ils sont en train de tester les poubelles dans les hôpitaux.
And we have 2 more technicians that are also testing it in hospitals.
Donc voici l'équipe qui travaille derrière le projet.
So this is our team behind the project.
Donc chers investisseurs.
So to investors,
investir pour Karange,
invest to Karange,
c'est contribuer à la réduction de la mauvaise gestion des déchets biomédicaux.
in order to improve the proper handling and management of biomedical waste.
Merci beaucoup.
Thank you. Thank you for the presentation. Merci pour la présentation. Yeah, I definitely can appreciate the gap and what the solution is going to. J'arrive à apprécier les lacunes et ce que la solution est. But I didn't see how much is he asking for. I may have missed it. Je n'ai pas vu de combien tu demandes, combien tu as besoin.
J'ai dit 500 millions pour couvrir le reste du Sénégal.
About 500 million CFA to cover the rest of Senegal. And production is in Senegal. Everything is produced in. Est-ce que tout est au Sénégal? La production est au Sénégal complètement. Because they have a prototype, right? It was manufactured in Senegal. Ça a été conceptionné au Sénégal. Est-ce que c'est ça?
Ça a été concepté au Sénégal. C'est la première poubelle intelligente orientée dans le domaine médical.
So this is a very first smart such bin that was developed in Senegal towards medical use. Merci beaucoup.
Yeah, that's a nice one. So my question is on that prototype that you have. What is it built from, and how is it powered?
Donc la question c'est ce prototype que tu as. De quoi est-ce que c'est conçu et quelle est la source d'alimentation?
Donc pour la prototype, c'est du bois, mais on va faire du plastique dur pour juste respecter les normes de la santé publique. Donc c'est juste un prototype.
Okay, so for the prototype, it's currently made out of wood, but we are looking at using higher grade plastic to respect the medical guidelines.
Donc pour la fonctionnalité, c'est de l'électricité et les power banks. Parfois, les hôpitaux, il y a des coupures d'électricité, mais quand il y a coupure, le power bank essaie d'allumer de manière en temps réel.
Okay, so the main source of power is wall sockets, but then there's also the potential of having power banks to also kick in if there's electricity light outage.
How does the sorting happen? So like when you put the waste in the bin, what's the technology internally that helps with the sorting?
Donc quelle est la technologie qui aide avec le triage?
Donc il y a l'apidia, le médecin, quand il a fini ses trucs, il met juste les déchets avec l'apidia et les capteurs. C'est à la poubelle de faire une rotation et de classer les déchets. Parce que dans la poubelle, il y a 5 bacs, les bacs à seringue, bacs à gaz, bacs à coton, bacs à fer et le foutoir. Donc tu mets le déchet et c'est la poubelle de faire une rotation, de classer les déchets de manière automatique.
So the bin has inbuilt sensors that are able to detect what type of material the waste is made of. And it has 5 compartments within it that is able to also use to separate the various kinds of waste, depending on what it's made of.
Is this proprietary technology?
Est-ce que c'est une technologie à vous-même?
Oui, bien sûr, bien sûr. Je l'ai conçu moi-même.
Yes, please. I built it myself.
Has he registered, like, does he have a patent on it, or is he working towards a patent?
Je l'ai déjà projeté. Dès que j'avais l'idée, j'ai protégé mon projet.
So as soon as he had the...
Un brevet. Le brevet. La protection. Dès que j'avais l'idée, j'ai protégé mon projet.
So as soon as I had the idea, I patented it.
Thank you very much. An extra round of applause for the interpreter. I don't envy him at all. Wow. Ladies and gentlemen, this brings us to the end of today's pitch sessions. Let me move to the other microphone. This brings us to the end of today's pitch sessions, and I want you to join me in giving all of our participating ventures a round of applause. I think we should give them a standing ovation. Standing ovation. This has been excellent. All of our ventures, well, very well deserved round of applause. Very, very great innovations that we saw. Thank you so much. Throughout the day, you can sit down. Throughout the day, we have witnessed creativity, courage, innovation, and a genuine commitment to solving some of the most pressing health challenges that are facing our communities throughout Africa. To every team that has presented here today, I want to say a big thank you for sharing your ideas, your vision, and your hard work with us. Before we break, we have two very important activities. First of all, we'd like to invite all participants to cast their vote for the People's Choice Award. So you can see the barcode right there. Please scan it. This is your opportunity to recognize the venture that stood out to you throughout today's presentations. We would have that happen. So a Menti link has been put out there, has been shared. We encourage everyone to participate. The results will be out during dinner time. So please take a few minutes, couple of minutes really, to participate, to select your favorite venture. Are we done? If you are done, say yay. No, not a lot of yays came out, so a few more, a couple of minutes, 2 minutes. All done? All done? No? All right. Secondly, we would appreciate your feedback on the Health Innovation Festival 2026, the complete 3 days. Your feedback will help us improve for future editions and better serve innovators across the continent. So we have an evaluation link right here. Please scan the code. We want everybody to take a few minutes to complete it before we leave this space. So take a few minutes, give us your evaluation. And while we are doing that, I want to extend our sincere appreciation to judges, mentors, partners, and volunteers for their time, expertise, and support throughout the past 3 days, and even before the 3 days, because planning was included as well. As we conclude on the daytime activities, we look forward to welcoming you back this evening for the dinner and closing ceremony, where we will celebrate the journey of the past 3 days, recognize outstanding ventures during the awards, and officially bring the Health Innovation Festival 2026 to a close. The dinner and closing ceremony will begin at 6:30 p.m. We kindly ask all participants to be seated by 6:15 to allow for a prompt start. Ladies and gentlemen, thank you once again for an inspiring day. We look forward to seeing you this evening. Thank you very much. Ladies and gentlemen, just a gentle reminder, closing ceremony